So the body and the thyroid gland, which is the butterfly-shaped gland here, makes two hormones. One is called thyroxine or T4, and that itself is converted to T3, which is probably a slightly more active hormone. Traditional replacement of the thyroid gland in individuals involves just T4, that is in the UK. On the continent in Europe and often in the States, it is completely routine to also add in T3 for the treatment. But for various largely political reasons, maybe financial in the UK, the NHS offers, unless in exceptional circumstances, just T4 treatment. So in my experience, there's around 10 to 15% of individuals who have hypothyroidism, whose biochemical testing shows that whilst their T4 levels may be adequately replaced with the use of levothyroxine, their free T3 levels are in the low or low normal range. And these patients often have symptoms compatible with ongoing underactive thyroid, and they benefit from the prescribing of additional pure T3 together with their pure T4 treatment. Well, the risks of thyroid treatment are very low if you get the right dose. So what we're trying to do in treating it is just to restore hormone levels to the normal, and in my practice, to the high normal range. So if you are, in the majority of cases, can be managed with the use of just levothyroxine or T4, that is the optimal way. It's cheap, it's stable, and we can adjust the dose relatively easy. However, as I've said, in around 10-15% of patients, they have ongoing symptoms of an underactive thyroid, despite the T4 and the TSH levels, the controlling hormone levels, being normalized. And testing often shows that they are low in free T3 and benefit from the addition of pure T3. And that way you can restore them to normal, or at least you can be certain that any ongoing symptoms they have are not due to untreated or poorly treated hypothyroidism. So the dose, like the dose of thyroxine, the dose of T3 can be adjusted according to the blood tests. Now, one of the downsides or the issues with T3, it is that it is much shorter acting. And so it needs to be given once, sometimes twice a day, sometimes very rarely 3 times a day in small doses. And it generally lasts 8 to 12 hours. So you monitor, in my practice, you monitor the blood levels of it around 4 to 5 hours after you have given it, which is when you should see peak levels. And then you can just adjust the dose of it to get those levels into the upper normal range. Now, if you give too much T3 and you make somebody over-replaced or overactive, and this is where some of the controversy comes about its use in the UK, then you will run the risk of giving someone fast palpitations, heart palpitations. Occasionally, it can cause an irregular heart rhythm, atrial fibrillation, which can increase the risk of stroke. And like with all cases of over-treatment with thyroid hormone, in the longer term, it can exacerbate the risk of thin bones or osteoporosis. So for both those reasons, it's sensible and good clinical practice to keep both T4 and T3 levels in the normal range and to adjust the doses of the appropriate medicines to achieve that. The main indication for T3 is those individuals who show have noticed ongoing symptoms of an underactive thyroid and where their T4 levels may be adequately replaced on their levothyroxine dose, but whose testing has shown them to have low or low normal T3 levels. And then you can restore those to normal. I would say, though, that not everybody who has low free T3 levels has symptoms of it. Some patients, it doesn't seem to affect at all. So as always, the main aim of treating patients with thyroid disease is to listen to their symptoms and to try and resolve them and restore them back to some degree of normality.